Hey, good evening, everyone. This is Shane Shuttlesworth with I'm the president of Osteogenics. Tonight we have Fadi Hassan and Dmitry Ivanov, and I need to invite them now. We'll give them just a minute to join. Hopefully they join any second. Looks like we've got several people rolling in. I see Dr. Hassan has joined. Oh, there we are. Hey,
Howdy, howdy.
how are you?
I'm doing great. How are you?
Good.
What's happening? How's everything been? Haven't seen you since Austin, I
Yeah,
think.
yeah, it's been good. Holidays, kind of crazy, and then it's back to work, right?
Finally, yeah, it was a little bit too much holidays for me. I was excited to get back to routine and normal things in my life.
Yeah, I
Yeah,
understand that for sure.
yeah. December was kind of chill, too much going on, and then January just right back to busy and crazy. This February, January was just overall busy.
Is is December a? I've heard that December is a people either tend to like shut the office down early or it's a super busy month.
Yeah,
Like,
for me, yeah, for me, it's usually kind of a forced vacation for like 2 to 3 weeks. Not continuous 3 weeks, but like very spotty with patients towards the end. Some patients do want to take advantage and do surgery, and a lot of patients don't want to do surgery. So it kind of end up being just little vacation. So I just take off like last maybe 15 days in the month most of the time.
hey, there we are.
How's
Dr.
it going?
Hassan,
Hey,
how
Fadi.
are you?
Good, how are you, man? How's it going?
Good. Well, hey, I appreciate you guys spending some time with us here this evening. Eric always reminds me to introduce myself and to introduce ourselves. So, uh, Shane Shuttlesworth, president of Osteogenics here, and tonight's guests are Dmitry Ivanov and Fadi Hassan. And maybe you guys can tell us just a little bit about yourself. I think a lot of the followers probably already know who you are, but for some who don't, maybe a quick intro.
Go ahead, man. After you, Dimitri.
Well, we as together we're the Perio Amigos. Neither of one of us are speak Spanish, but we're true amigos. We're more like familia amigos kind of thing because we've become very close friends and more like family at this time. But I'm Dmitry Ivanov. I'm from Los Angeles, California. I'm a periodontist and implant specialist, practicing pretty much mostly in OC and a greater Los Angeles area. And Fadi is Fadi off or
Are
what
you still
happened?
here?
Oh, he's still here. I don't see him. So Fadi, we've been together as Peri Amigos since 2021. We've just completed our 11th course together this past weekend in DC. And it's been pretty great ride so far. And maybe Fadi can introduce himself a little bit more.
And I think he is frozen, but I
Oh,
still see him in the screen. Fadi, can you hear us?
I can't see him, but
Oh,
uh,
here you go. He's requested to rejoin. Let me.
there you go. Yeah, so we've been doing these together courses as Peri Amigos since 2021, and been kind of growing slowly in various
There we go. Sorry,
very
it kicked me
areas.
out for whatever reason. I'm all of a sudden I'm here, then next second I'm not here.
Yeah.
Uh,
So we're just finishing, or I finished talking about myself a little bit about Peri Amigos. So just want to give you a chance to introduce yourself too.
so I'm Fadi Hassan. I'm the other amigo, 1 year older than this guy over here next to me, and we just had a great 3 day course in DC. I live in DC actually, and I practice between DC, Maryland, and Virginia, and I just opened my practice actually about 8 months ago. So I'm kind of there, almost getting into full-time mode, hopefully in the next 6 to 8 months. And but yeah, that's my story.
Awesome. How'd you guys meet?
Instagram.
We blame Instagram.
It's always Instagram, and thanks to COVID, I have to say, COVID was a blessing in disguise. And we just started talking and chit-chatting and, liking each other's cases and talking more about it. And I guess kind of Instagram pushed us in a way as like, about, potentially doing courses. And we both love gums so much. And so that's how we started. Like, we had that first discussion maybe 2021 and 2020.
20.
Yeah, and our first course was not until a year later. It took us about a year to plan it and get everything on board. And we're just celebrating finishing our 12th course actually this year so far.
It's actually
11th
course.
Right? Yeah. Okay.
11th
It's 11. It's 11.
I miscalculated when I told you earlier, but I just counted 11.
Okay.
11 it is.
Yeah,
Our 12th one's coming in April.
Yeah, 12th one will be in April. That's right.
Mm-hmm.
So that's going to be a good one.
Awesome. So, yeah, let's talk a little bit about. So, for the audience, if you guys have any questions, please put them through. There's a little question mark, at least it's in the bottom right of my screen. You also can put in the comments, and we'll probably see it there. But we'd love to get your questions asked and answered. And if we don't get any questions from you guys, then I'll just keep asking mine. But I'd love to have you guys join into the conversation.
Absolutely.
So, my first question for you guys is just let's just talk about the courses a little bit. It's kind of a new thing, but now you've done several. You're about to do the 12th coming up in April. Where do you do them? Where do people who want to learn more about like what content do you cover? Where do people find out about it? And then what locations do you do these at?
Good.
Fadi and I, as he just mentioned, we kind of started brainstorming about the things in 2020, and we sort of had an eye to eye on a lot of soft tissue things. And our flagship course, or kind of the origination of the Perio Amigos, started with covering the soft tissue, because no one really covered the soft tissue as a topic in variety of things, out there in 2020. So we thought we're just going to start with soft tissue because we do love soft tissue management. So gum grafting around teeth and implants, and how to manage certain things. And then we kind of switched gears because our big part of our practices is implantology. Both Fadi and I, we do quite a bit of implants. I think more than 50% of our practice is implantology sometimes. And we started introducing bone component to the practice, or to the course. So we switched from just purely soft tissue grafting courses to more of a bone management courses, so like a comprehensive tissue management course. And then this year, we're introducing 2 more courses. One is going to be an implantology soft tissue only course, and that's going to be with Ricardo Kern. If anybody knows here, he's a fantastic clinician, a surgeon from Brazil. We are kind of humbled that he's joining us, forces for 3 of us. So super excited to learn from him. I'm sure Fadi feels the same way.
Oh, yes.
And then we are opening another new course, which is going to be kind of aesthetic zone implantology course, where we can talk about and practice shaping tissue with temporaries, and how do we do some grafting around the immediate type of implants and stuff like that. And perioamigos.com, that's been kind of a platform to share things, what we do, courses, and people can look into things that we teach on that website.
Are they hands-on? Is that didactic, hands-on, 2-3 days?
So it's 3 days. So far, like we started 2 days, and since we implemented the hard and soft tissue component, we've been really focusing. We're doing the 3 days. So it's a hands-on like each day. The morning's always a lecture section, and then the afternoon is always a hands-on for fresh pig jaw. So they get the 3 days of hands-on. Where we're doing, heavily soft tissue, mainly day 1, day 2, but we tend to cover a lot of extensive materials. And day 3 is usually a lot of our hard tissue component with implant placement and so on. And we also get to show a lot of our complication cases, like what happens when, I always like to say, when you do these surgeries, you have to know how to manage complications. So we always like to show our own complications that we get to, how when they do show up, when they do manage, and we all have them, so there's no denying that we don't have them. And I think that's the best part about learning, is that it's not just about doing it. Hey, I'm coming for the course, but no, what happens when shit hits the fan? What do you do then? So just being realistic, and that's the beauty about it. Like between me and Dimitri, we always have a tendency to show our our beautiful Instagram cases and our also not so great cases. Like this is what happens, So, and it opens up great discussions, and as far as how to think outside the box when complications do happen, and what materials, tools that we have in our armamentarium to help kind of hopefully fix it and move forward with that. So, that's what we really kind of always want to focus on, and it's fun. It's like really educational. Like always great questions, great attendees, different specialties from perio, pros, oral surgery, general dentists as well. So we get a good variety, perio residents as well, oral surgery residents. So it's been incredible, like just teaching a huge group out there. And I think Dimitri was saying, with like luckily, over 150 dentists, a lot of different countries as well that have visited the United States just to take our course. So we always feel humbled. We want to give our 110%, that they leave with hopefully a wealth of knowledge, and that they learn something at least to apply.
So you talk about complications. It's interesting. We've done, I've been in this business for 23 years, and we've done a lot of CE over the years, like live, and then also we do social media posts. And anytime we do complications, it's always the most popular
Always.
topic. It's like,
oh my God,
like it's what
people, you'll
want
see the comments. Yeah, it just never ends. It's great. I love it. It's the best way to learn. Like, was just showing them. It just shows who you are as a person. Like, Ken, I'm not bulletproof, and no one is. So I think I was talking to Dimitri like about a case that I posted a story on, and all of a sudden my patient's calling me about complications. Like, what's going on? And I showed Dimitri the pictures. Like, do you see something going on in my case? Like, I'm trying to figure it out. So it's always good to brainstorm these cases, like what we do to manage it. What medications to take and all that stuff. So that's the part where it's a learning curve. I mean, again, you can't teach 3 years of perio in 3 days. We all know that, but
Exactly.
we do get to at least show them, start something small, build on it, take more future courses, learn from us, learn from some other people as well, and that's how you build your experience if you're going to want to get into it more. And we all did that. When we finished residency, I 3 years of perio didn't teach me everything. It's that taking more advanced courses with my colleagues and learning more about other stuff, and that's how you get slowly to that level.
Yeah, that's a very good point, because a lot of doctors that reach out to us, and we get texts and emails asking questions about our course, and everybody thinks that in the 3-day they're expecting to learn everything under the sun to be able to perform advanced surgery, right? And they're like, is your course gonna teach me everything I need to know about GBR, right? So you have to be realistic. You got to come in with a certain amount of knowledge, and there's like basically build on the existing knowledge, like Fadi said, not just taking one course, but taking more courses and learning. We didn't learn a lot in residency. We learned the basics, how to crawl, but then you have to walk, and then you have to run. It's the same concept that people take courses. We are welcoming everyone, and we try to cater to like a broad spectrum of doctors sharing like small details of small cases to complicated. But like, you have to be realistic. If you don't know a whole lot, you have to continue learning. So that's big takeaway with the doctors that are reaching out to us. I always tell them, just keep building on that, and keep keep learning.
Awesome. Last question about the courses, then we're going to jump into some clinical stuff.
Yes.
Where are they? You said you just had one in DC. Are they all in DC? Do they bounce around the US, like generally geographically?
I mean, so normally we keep them at least, one East Coast, one West Coast. So our goal is like anywhere between 4 to 5 courses a year. So like this year, our first 2 ones are in the East Coast. The next 2 ones are most likely going to be in the West Coast. And then we'll go back East and West, just because we are adding kind of different materials this year as we're, for 2024. So we're really also kind of testing the waters as far as different cities and different states. We go to where my hometown is and where Dimitri's hometown is, just for convenience as well. So they get to experience that at least. We haven't thought about like doing in different parts of the country at this point in time. Right now, where I think we're so far, we're trying to build the name yet, and slowly, hopefully, if opportunity presents itself, then we'll definitely glad to branch out to different states in the future. We never know.
Got it. Awesome. So perioamigos.com, find more information, and I'm sure also through your Instagram pages, probably also find more information there. And you have a Perio Amigos Instagram page also?
That's correct.
Yeah.
Yeah.
Awesome. So jumping into some clinical questions. So last time we talked about, and this is for those who maybe maybe you weren't at the first one. This is kind of our second. This is part two of interviewing the Perio Amigos. And in part one, we talked some about soft tissue grafting. We talked about allograft versus autograft. And I know we talked a little bit about tunneling, but I'm just, as a follow-up question, do you guys do all tunneling, like vestibular access for root coverage? Is that the go-to?
That's a tough
That's it.
question. Very loaded question there. It's like, yeah, well, I'll let Fadi answer what, we both have preferences, obviously. We both have like, the favorite club in your golf bag to use for, getting out of tough situations. It's 56 degrees, or it can be a sand wedge, but both of us have preferences. Fadi, maybe you can chime in. What is
Yeah.
give a quick.
My preference has always been, I mean, I love tunneling for most of my cases, but honestly, open flap like Zucchelli style it's one of my fastest ways of doing soft tissue augmentation. And kind of whether I'm adding autogenous, non-autogenous graft to it. I really enjoy open flap, but tunneling, I mean, I do favor it a little bit more just because of the aesthetic component to it more. I would say, especially the initial part of it. Eventually, I always like say by 6 months they look the same. Like whether open flap or tunneling, they all look the same. But if you want incredible coverage, I would have to say open flap Zucchelli style is always going to be a little bit up there.
Yeah, I think the answer is really hard to
It
answer
is.
your question in like terms, because there's certain situations where you have to use a flap. For example, there's either a muscle that's very involved, or just the situation is not favorable for a tunnel. It'll be challenging, and the outcome will be compromised. So, again, to answer like, will you learn everything in the 3-day course taught for soft tissue? You have to understand that it all comes. It's like a clinical decision making, more of a learning process. You can't just like A plus B equals C. There's sometimes A plus B might equal to D in some of these clinical cases. So I think you have to.
So you're doing, we're keeping all our options open, doing some tunneling, some open.
But tunneling is preferred to us because, again, it gives us the most aesthetic result. As far as complications, if things kind of sort of with the flap may not look as good or something may have an issue with a flap type of approaches versus tunnel. This what I use, 3mm hole technique. Fadi likes to tunnel conventionally more sometimes, which is what he was trained on, and I was trained with the 3mm hole Vista technique in residency.
Okay. Awesome. So let's move to hard tissue. I got a question. So for sinus elevation and immediate implant, I think you guys are using some NovaBone in some of these applications for crestal sinus elevation. Maybe you could talk a little bit about that. And then I'm also curious, are you doing that in coordination with osteodensification, or are you doing it separate of that? And maybe just talk a little bit about what are you doing with sinus elevation and immediate implant placement in the maxilla.
Go ahead, man.
A lateral window has probably been always one of my favorite procedures, to be honest with you, in residency and after the residency. But it is more lengthier, a little bit more involved. And I think since I started using DensaBurst, since graduating from residency, I kind of stopped doing lateral windows because, or at least I decreased the number dramatically. And since I actually got exposed to NovaBone, which made my life a little bit easier, it's more of a delivery system rather than anything. I mean, I could get very good elevation with allograft or NovaBone, but I think NovaBone delivery system gave me ability to really just do it with faster approach, and I find it a lot less perforations with the crestal approach using DensaBurst. But 100% of my crestal lifts are done with a DensaBurst. I do incorporate what I like with NovaBone with the very wide defects and crestal defects. I start with NovaBone and I lift the membrane with NovaBone. It may not lift quite a lot at first, but then you start pushing allograft right NovaBone, and that's going to create a more kind of a bigger volume. So I've been using that to come in combination, because NovaBone is like a good delivery system to lift initially. Because it flows. it really separates the membrane, and then I can use an allograft to truly elevate because it's more denser.
Yeah, that makes sense.
Yeah, so that's been my experience. I don't know how Fadi approaches that.
So
His
I actually haven't done a lot of like combination between Novabone and like allograft. Something that definitely I've been in the past. Definitely been using a lot of like I definitely use Versas like for the last
Okay.
9 years. I've been with Versa burrs, almost 10 actually since I was in residency now. And but like using Novabone on vertical sinus lifts, it's just definitely makes it easier. I've never tried the mixing though, so
not
that
mix. It's more of like a
I'm like,
layer.
yeah, like the separate layers. Starting Novabone first because it's more softer material, so it doesn't cause any perforations versus like the particles
That's
itself when you're trying to condense it. But I mean, again, something I use, anytime I get a vertical sinus lift, between either allograft or Novabones, kind of whatever's available at that moment in time. Sometimes I work in different offices, so they have one product versus the other. And whatever's available, I'll tend to, of course, always go ahead and use it as well. But yeah, it's definitely been a definitely game changer for like especially for vertical lifts. No doubt about it.
the size. I mean, the biggest game changer for at least in my practice been the amount that I can elevate safely, because like I said, sometimes there's a fine line between lateral window and a crestal approach for me. And that really depends on the width of the sinus and how predictably it is to lift, vertically. So Novabone does have, at least in my practice, helped quite a bit in that sense to kind of decrease the amount of lateral
Yeah.
windows.
Yeah. Awesome. Yeah, thanks for that. And so there was an earlier question about, this was like early on, just question just generically about and this is like a good lead into it. And the question was using allograft versus using synthetic graft. And then we just talked about using Novabone, which is a synthetic, or an alloplast, and then also using an allograft there in combination. But just to answer the one question earlier in the chat, are there other, so we know in the sinus elevation, for crestal sinus elevation, it sounds like you're both using some Novabone. Sounds like Dimitri, you're also then adding some allograft in like a layered approach. Are there other areas where you're using, maybe just talk about graft materials? Are you using mostly allograft in other places? Do you use xenograft? Are you using alloplast in other areas?
Great question. We both are kind of together on this one. We really like xenograft too much. We maybe used to use it, and I mean, Fadi, maybe you still do, but I haven't used xenograft since residency, to be honest with you.
I've used it once since residency. I think the only material I use is maybe like a collagen based xenograft, that's usually for. Again, depends on the office. Like if they have it, I'll use it maybe for like an immediate implant, like in the buccal plate, like to graft the buccal gap. Sometimes even with a vertical lift, I've used a xenograft collagen. Again, just depends what those offices do have, at least in there. But I think it's pretty much almost 99% allograft. Yeah. I mean, for normal standard extraction, socket presses, ridge augmentations, and so on.
Yeah, I think we're very fortunate in the United States to have good access to a very good quality allografts. European countries, where some countries are illegal to have allografts or maybe not have good quality, like the processing of the bone. I think we are very fortunate that the bone that we get, I think we really truly don't need a use of a xenograft in a lot of things. And plus the lack of remodeling of that bone and just leaving the xenograft as is, that's kind of been the driving force for us not to use it, because we can get a very good a converted real bone from the allograft, which has better resorption.
Gotcha. Perfect. Speaking of allograft, I have a question. So when you guys are picking which brand of allograft, is it mostly price? I mean, from a disease transmission standpoint and from a process, most tissue banks, and we have a tissue bank also. So it's like most are following, are meeting FDA, and the better ones are also meeting AATB guidelines. And so, in the US, it's fairly consistent from like a safety profile, in my opinion. But then there are little things you can do to differentiate, what if it's in a bowl versus a vial versus things like that. But then there's also particle size consistency. There's clinical research on different combinations. There's, testing for BMP2 or for osteoinductive potential for demineralized bone. And like, so at Osteogenics, we have our Encore allografts where we try to incorporate all the best practices. So we've done like 6 RCTs at the University of Texas Health Science Center in San Antonio Perio program. We have, we test for BMP2 and osteoinductivity testing. Like we do all these things that we think are best practices, but then it carries a higher price. And then, a lot of people we come across are just like, I need it to be, are more price sensitive. Where do you guys land on that? Do these little things matter, or is it kind of like they all work pretty well? So, it's more of a commodity in your
Do you,
eyes.
do you guys still use MTF as your bone bank?
No, we have like
Or not?
upstream suppliers, but we do the final processing and packaging in-house.
Oh, got it.
And it's not MTF, but in terms of the processing, everyone has their like branded
Yes.
version for like making sure it's free of disease transmission and cleaning and decellularization and lyophilization and all those things.
Yeah, I mean, we believe that cheap bone is not good
Yeah.
bone.
I agree. I agree with that. I mean,
Cheap
yeah.
bone is not good bone. Yeah, not all bone acts the same, and it has to, same with the particle size being, variety versus more uniform. I think, it is definitely more important to select a company that has highest standard of care, not just the FDA approval, but also, processing and things. So yeah, we don't believe that cheap bone or any bone works the same, because you'll get the results. And a lot of times the bone, when you open, it's going to be soft. It's not remodeled. It doesn't change into, real bone over time.
So for
So,
you, maybe it's about placing it and seeing the results, and that's where the
well, I mean, I think if you're going with any of the top companies, top 4 or 5 companies on the market that gives you bone, I think that's most of those practices are very, very legitimate.
yeah.
So, going with anything cheaper and that comes from another country or something like that, I would take it
Yeah.
seriously to look at how the things were done.
Okay. Yeah. Appreciate that. Couple more topics, and then man, time is really flown by here. So PTFE membranes. I think you guys both maybe use some PTFE
A
membranes.
lot.
So there's
A
uh-oh.
lot of it. I buy a lot of boxes of PTFE from Osteogenics, and my assistant keeps goes like, "We're running out." It's like, "Need to get more," and I was like, "All right, I'm gonna get different sizes now because that's my working horse is the PTFE membranes, and every time I go in with reentry, I mean, it's just incredible. I mean, hands down, even with ridge augmentations,
So you're doing both.
socket preservations,
You're using
I,
both. Okay.
yeah, it's just, I mean, that membrane is my working horse, literally.
Yeah,
Like, I need to actually order now. My assistant just comes like,
I'll take your order
you're
here.
running out. I was like, how much? Like, I just ordered like $5. Like, okay, we're out of it. It's like, God damn it, I need to order more.
yeah. I'm usually looking out for those emails, the holiday emails, like, hey, $100 off. I was like, I'm about to
I
stock
just
up.
buy a stock of it.
I was like, I
I think
need that.
that's what I did last time. Like, it helped me for like 3 months, and I was like, shit, I need to order
It's
more.
usually
But
the end of the quarter when things are getting tight. We're like, all right, we gotta-
Hook us up, hook us up.
I think, I mean, since residency, both of us, we've been heavily in use of your guys' product as far as PTFE membranes. I mean, they're unbeatable as far as quality. And I mean, I don't do a socket graft without a PTFE membrane, to be honest with you.
Amen.
Fadi likes to sometimes do a little bit of collagen. I'm a
Not
little
anymore. Not since I
sure.
opened my office.
Okay.
Since I opened my office, has been zero collagen membranes
Oh
for
yeah.
my socket grafts.
I was like,
Zero.
I
I see. I've finished out 4 weeks, and I removed the membrane,
yeah,
and
I
you
like
see the beautiful pink
night
tissue. It's
better.
just, yeah, I love it.
So when you
Yeah.
guys are soft tissue guys, one of the things that we always advocate. I just wonder if this resonates with
Mm.
you or if it's more about just predictability and price. But like the like leaving it purposely exposed with a dense PTFE
Hmm.
membrane, which is designed to withstand exposure and not get infected, like you get an increase in keratinized tissue width. Eliane Barbosa studied that 20 years ago. And is that a critical point? Is that just kind of like an interesting like, or is that like the reason you do it? What is the primary reason you use PTFE? Maybe
So,
that's a
so
more
two
precise
things. Number
question.
one is the bone quality. I feel like when I'm using coming back in for reentry bone quality with the PTFE membrane, especially I like to wait 4 months for my implant placement. That's my standard. And it's just type 1 bone, and I like our type 2 bone. It's just high dense bone quality, number one. Number two is, and you maintain the shape of the ridge. Like I don't lose one bone particle when I use a PTFE membrane on a broad spectrum every time consistently. What I love is consistency. Number two is I do get that nice tissue. So for me as a periodontist, when I'm placing my implant, whether it's a premolar or molar, I get to roll that tissue to the facial because I have a nice amount of nice tissue I can play with, and I can add more bulk to the facial of that site. So for me, it's a 2-in-1. Like I get both benefits in those cases, and you can't find something that beats that. As a periodontist, like we love those things. Like it's the small fine things that just complements it, you know?
Yeah, no, I'm with Fadi the same way. I think the key to at least socket success is how much or how less bacteria you will get in that top layer, like from the healing standpoint initially. So PTFE membrane allows us to create a seal, fairly quickly. When those dimples, as long as they're aligned correctly, it creates a soft tissue seal right on top of that. So the top of the bone, which with the collagen membrane or anything else, it's sort of gets mushy, and dissolved, whereas PTFE membrane kind of protects the area from anything entering into that space with the bone getting covered with the granulation tissue,
Yeah.
and creates a seal. So that's why the Fadi finds, and I myself find, a much better bone quality right at the top instead of more softer at the top and then denser at the bottom.
Got it. Last two questions. One from the audience, and then so the first question is the question was with your PTFE membranes, do you strive for primary closure or not? And I can imagine it's situational. So
It
you
is.
could
It is.
talk.
It is situational.
So
It is. I mean, most of the time, not.
Depends
It's
on
a
the
case
type.
by case. Yeah. I mean, if it's a big ridge augmentation and like with a simultaneous extraction socket graft, I'll tend to use the bigger one. I'll aim for a primary wound closure. I'll close it up. But the beauty about it is that when I come back 6 months later, you have a PTFE membrane that's non-titanium reinforced, just a dense PTFE, but you remove it, it looks like you just use a titanium reinforced membrane of how stable it is. So that's the beauty about that membrane. Like I had a case I saw it last week for a 3-week follow-up, and I used a dense PTFE membrane for extraction with a ridge aug, and you can see the whole ridge just beautifully like wide, and I was like, oh, this is gonna look beautiful on re-entry, And I think Dr. Neva also, I know he's joining
yeah,
us.
saw that.
He's also talking about sutures and glycolon. Hands down, as a suture that I use, I mean, my office is all resorbable sutures, and like 99%. I don't think I have one PTFE membrane, but I love using glycolon and my proline sutures, like just for like soft tissue. But glycolon is my working horse for socket grafts, ridge augmentations, pretty much 100% of the time. Like I don't use other ones besides those. So it's a really good combination from a suture stability. It's loses tensile strength about 2 to 3 weeks later, 50% of it, and lack of bacteria wicking on it. So it's, I mean, they all add up to each other. Like it's the small stuff here and there, but they add up to each other.
Yeah, appreciate that. So last question. We're out of time. The next course, you teased it early at the beginning. You have your 12th course coming up. Where is that, and when is it?
So that's going to be the last weekend of April. It's a Friday, Saturday, Sunday, and it's going to be also in DC. I think we're about almost 50% sold out at this point in time. So we have definitely more seats left to hopefully fill it in by then. And again, we're joining us by Ricardo Kern, who's one of our greatest friends, really dear friends that I've known pleasure for like the last 4 years now. So hopefully will be joining us from Brazil and coming there, and also learning from him as well. He's an incredible clinician, and I'm excited to see what he's going to show us as well. And hopefully between me and Dimitri and Ricardo, all three of us, we should have a really good audience, and hopefully we can deliver something very unique and different for all the people who are going to be there.
This is hard-end soft
It's
tissue,
Nope.
it's
or it's implant?
it's exclusively soft tissue for dental
All
implants. So
soft
it's a
tissue.
real,
No.
yeah, it's exclusively.
Yeah, no teeth, just management of tissue around implants, and all 3 days will be hands-on, showing basically a variety of procedures between myself, Fadi, and Ricardo, to kind of everything under the sun to manage implants and soft tissue. We're not going to talk about teeth.
No teeth, all implants and all anterior aesthetic cases, most likely implant site development with like soft tissue augmentation. So
Yeah.
it's going to be again hands-on from tunneling, open flap to VIP CTGs to tabletop to rosteographs, you name it. It's going to be there.
Awesome. Well, looking forward to that. Congratulations on your success with the courses, and
Thanks, Shane.
really appreciate you guys spending some time with us, and appreciate the collaboration with you guys. So thank you so much.
Yeah.
You're welcome. Thank you, man. I really appreciate your time.
Yeah, thank you, Shane. I've gotten one case back. I used your guys' allograft.
Yes, same here.
Soft tissue allograft. I used it on the upper left quadrant. I actually did a little split mouth. I did upper right with the CTG, and your allograft with your dermis, with your allograft, soft tissue allograft. It looks really good. I mentioned to you some of the things that I kind of made mistakes on during the hydration. I overhydrated.
Yeah.
So, but I think the next case that's coming up, I'm going to do another quadrant. That's going to be a lot easier to play, because that thing got so huge when I hydrated it. I was like, holy smokes! It's like 4 millimeters thickness graft.
It's supposed to expand like 20, so like 1.2 millimeters to like 1.5. It shouldn't.
It was bigger than 1.5. It was like this thick. I was like, what? But I did hydrate it for like freaking 45 minutes.
Yeah, Eric told me that you hydrated it 29 minutes too long, which made me think it must have been for 30 minutes.
Long, yeah. But, the next one is going to be placed, dry, as you said, right? It can be placed dry, and
then just soaks up blood.
Soaked in blood and place it. So I'm looking forward to that allograft return. But if it gets as thick inside the tissue, that's money.
Yeah.
Yeah.
Fadi, have you got your case back, or
I got
still
my case back? So I actually used it for a tunnel technique, and it was a really tight area. And I think I pushed a little bit too hard, and I actually made a small tear into it. And I was like, but I was able to kind of salvage the case and still use it. It came back actually, and tissue response was beautiful. Like none of that inflammatory response. You get to see nice tissue thickness, not over bulky. I have some patients like complaints like the graft is just too bulky and it's uncomfortable for me, but this is just like really nice tissue blending, and the color was unbelievable. Like a 2-week post-op looked like almost like a 6-week, 8-week post-op in other cases. So I still have another case I'm planning on using. I want to try this time open flap approach just to see, and also I hydrated a little bit too accidentally, but for like 5 to 10 minutes, not 45 minutes.
We say literally 60 seconds is all you need with that.
I think that was like maybe 5 to 10 minutes, a little, not 60 seconds.
Yeah.
But I want to try with an open flap approach, because for me, I want to always like to compare 1-to-1, and hopefully we'll see how that looks. So I'm excited to try for another case.
Awesome.
Yeah, looking forward.
Well, hey, thanks, guys. Appreciate it. This was great. I feel like it could go on for another half hour, but we'll let you get to your family and dinner and all those things that we do in the evening. So
awesome, man.
Take care. Thanks for your time, and hope to see you soon.
Take care. Have a good one.
Bye.
Good night, Habibi.
Bye-bye, Habibi.